So compassionate care, can it be taught? Understanding compassionate care and why it is important. First of all, why is it important? If you'll see my lovely Google search history there, as behavior analysts, we're kind of deemed as robots, right? I like this robot guy with the pizza. I think it kind of sums up who I would be as a robot. And in reality, we're not robots. We're just often accused of being as such. With the rigor and structure that behavior analysis is based on, without formal instruction on compassionate care skills, it's understandable why so many view our instruction as robotic. We as a field need to do better. That's what we're predicating this on. So, defining compassionate care from the perspective of a behavior analyst can be tricky. A lot of the definitions are based in deeply mentalistic terms and saturated with feelings. Gross, right? As much as the world would like to think that behavior analysts aren't are robots, we aren't. So therefore, I invite you on this journey of suspension of disbelief. We're going to see more concrete parameters in terms of definitions as the time progresses. So just a breakdown of the definitions over the years. We'll see a gradual development. Try and pick out some of the keywords, and later we're actually going to create our own operational definition. So in 2007, we see a definition of compassion brought to us by Roach, and that's an immersion into pain, brokenness, fear, and anguish of one another, even when that person is a stranger. Fast forward to 2010 with a good old-fashioned Merriam-Webster. Compassion is a sympathetic consciousness of others' distress with a desire to alleviate it, feeling and exhibiting concern and empathy for others. Lone in 2004 defines it as the recognition, empathetic understanding of, and emotional resonance with the concerns, pain, distress, and suffering of others, coupled with motivation and relational action to ameliorate those conditions. That seems like a mouthful. I don't know if we went towards a behavioral definition or backwards there, but I do like it in its essence. But finally, that brings us to 2021 with Rohr et al., and that's an empathetic and collaborative process that promotes parental caregiver involvement, is non-directive, personal, and is likely to lead to continued services, empowered families, and positive experiences with ABA. Obviously, out of all of these, the 2021 definition is a little bit more solidified in behavior analytic terms, but I don't think that discounts the importance of the three prior years, or prior defining years. So just as important as defining compassionate care, we also have to figure out a way to measure it. What I figured we would do was compare and contrast three scales. The first being the compassionate care assessment tool. So we're going to call it the CCAT. The second being Fogarty's compassion scale, the CS. And then finally, the 12-item Schwartz compassionate care scale. So we're going to compare all three of these. My computer's just waking up slowly. There we go. So again, comparing these three different scales, the first being the CCAT, the compassionate care assessment tool. This one was interesting in that it was distributed in clinical settings as part of the outpatient process. It's a combination of a spiritual needs assessment and a caring behaviors inventory. It's an assessment of the top 5 ranking questions by patient agreement of importance, of which included helped control pain, the physician understood a medical issue, worked competently, the physician is skilled with equipment, and then ultimately that the physician treated them without judgment. And these questions were ranked on a Likert scale 1 to 4. The second scale, the Fogarty's compassion scale, CS, was a slightly different analysis. Patients were shown 2 videos. The first video had a doctor who explained the treatment process for his patient's cancer and essentially defined the cancer, explained the treatment process, and ended the conversation with, if you have any questions, please let me know. The second video did the exact same, except it added 40 seconds of compassionate phrases. These phrases included, I know this is a tough experience for you to go through. I want you to know that I'm here for you. Some of the things I may say to you today may be difficult to understand, but I want you to feel comfortable in stopping me if I say something confusing, and that we're in this together. We'll go through this together. Spoiler alert, ladies and gentlemen, these extra 40 seconds reduce patient anxiety significantly compared to the control group. Furthermore, This was directly correlated with the likelihood of the patient's adherence to the treatment plan prescribed by the doctor as compared to the control group. 40 seconds. It's less than a minute and had such a huge impact. The final scale is the 12-item Schwartz Compassionate Care Scale. Does anyone want to guess how many items the 12-item Schwartz scale had? Is it 12? Did you guys guess 12? You're on it. I love it. So 12 items. These were discussed with a group of non-hospitalized patients that were used as the sample size through an online platform. Ultimately, the goal in this scale is to gauge compassionate care and its gaps in demonstration. So it's slightly different than the other two, but still with the same goal. The 12 items included expressing sensitivity, caring, compassion, striving to understand emotional needs, considering the effect on the illness and those that you love around you, listening attentively, conveying info in a way that's understandable, gaining trust, involving the patient in decisions about their treatment, comfortably discussing sensitive, emotional, and psychological issues, treating the patient as a person, not a disease, showing respect for them and all those that they love, communicating results in a timely and sensitive manner, and spending enough time with you. Again, just kind of that throwback to the Fogarty's compassionate scale is, I mean, time is everything with these patients. 40 extra seconds makes a difference. So if technology allows me, we are going to watch some very poorly edited videos. I would like to think that I'm a fabulous actress, but in reality, probably not. So bear with me. And I hope that you can hear them. But because they were shot on an early model Android phone, I encourage you to turn your volume up all the way. Okay, team. So you'll have to let me know if we can hear this. All right, man. So what's going on? Tell me a little bit about what brought you in today.
So over the last couple of weeks, my anxiety's been really, really high still. I've had hard time sleeping, focusing on things.
I mean, that's just the generalized anxiety disorder. The coping mechanisms we talked last week, are those helping at all? Are they?
I don't really feel like they are.
Are you doing them right? Because we talked about the procedure that you're going to do them. So the step-by-step, are you following every step?
I believe so, I am.
I think you should just try harder at them.
Okay.
So could y'all hear that okay?
Yeah.
Perfect. Yes, technology worked for me. I'm so thrilled. So all my keyboard warriors, take a minute, just kind of help me analyze, how did that feel? How did that, it felt icky to make. So how did it feel to look at? Very confrontational. Yep.
Yep.
Mm-hmm. Unkind,
Cold.
dismissive, cold. Yep. All of this. Absolutely, guys. Ooh, patronizing. Mm-hmm. Yep. Awesome. Great input. Appreciate it. So, yep, that was pretty much what, I don't want to say we were aiming for, but that's what became of it. So I'd like to watch a second video where hopefully I was less of a jerk. All right, ma'am. Thank you so much for coming in today. What brings you in?
So just over the last couple of weeks, my anxiety still has been high. I haven't had much sleep. I'm on edge. And I don't know what to do as far as taking the next step to address those issues at a more deeper level.
Okay. Now, I know the last time that you and I spoke, we had gone over some coping mechanisms. Have those been helpful at all?
I feel like they're helpful sometimes. I think maybe if we go over them again and maybe do like some scenario based things, that I can get more of an understanding if I'm doing it right while I'm at home.
Absolutely. The most important thing about this is I can provide some tools, but if they're not working for you, then we definitely need to pivot and make sure that we can find something that does work for you. Does that sound okay?
Yes, thank you for your help. I really appreciate it.
Of course. Awesome. I will take my Oscar now if anybody wants to submit me for such. So differences there. How did that one feel? Again, I mean, wonderful acting aside in the fact that it was shot on a Android 1.0. Right? We're seeing supportive, warm, open and friendly, caring a lot better. Yeah, it was a lot better. So this is welcome to the human race. Thanks. I'm new to the game, but I'm trying my best. This is an obvious comparison, right? And oftentimes these things are not so black and white. It's not one cruel clinician versus a very kind and warm and open clinician. But sometimes what happens, especially in our field, is we get so hyper focused on defining a problem and fixing a problem that we stop listening. And ultimately, that's where the teaching these compassionate care skills is going to help us fall back on. So thank you for that. I appreciate your time and your feedback. I'm happy that I can be at least a little human sometimes. So that was attempt 1. We went to attempt 2. Again, computer's just waking up a little bit. Come on, you can do it, buddy. So where is the overlap when we measure compassionate care? If we're reviewing all of these skills, when reviewing all of these skills, it ultimately brings us to a conclusion lying in an unofficial IOA of sorts, the overlap. If we look at all 3 of these compassionate care scales, all 3 scales emphasize the importance of 1, the provider easing pain, anxiety, and emotions associated with the treatment and acknowledging these sensitively and attentively. 2, the provider understanding the issue at hand and explaining it in a way that helps the patient understand the issue and options. This is the one that behavior analysts would really, really need to take note of. And 3, that the provider does not judge and encourages the patient to ask questions and be involved in their treatment. Now, this of course doesn't discount the importance of the other parts of the scales that don't overlap. So the Schwartz Compassionate Care Scale really emphasizes including family members in decision-making when it comes to treatment. I think it's important to include family members, the family members that matter to the patient in these decisions. But if we're looking at this simply from a basis of overlap, then these are the 3 most important takeaways. Now, where does learning history come into play when it comes to compassionate care? Learning history of soft skills is ultimately really the same process as any other skills we would develop. This starts when we're young. It develops the same way that any other emotional disposition would. It follows the lines of reinforcements and punishment and contingency management and verbal behavior and rule-governed behavior. All of these things factor in. Now, what's really interesting, according to a study by Lumo and Platt in 2015, is that soft skills such as compassion develop very similarly to other emotional dispositions such as shame, self-criticism, and self-stigma. If you think of this from the perspective of a relational frames theory, if you look at yourself with compassion, you are more likely to view others with compassion. However, if you view yourself with shame, criticism, and stigma, it is more likely that these kinds of emotions are going to be what generalize to others. So this leads us to an operationally-ish defined compassionate care. Just kind of throwing it back to the key definitions we discussed earlier, Roach in 2007 discussed it as an immersion into pain, brokenness, fear, and anguish of another, even if that person is a stranger. Merriam-Webster defined it as the sympathetic conscientious of others' distress with a desire to alleviate it while feeling and exhibiting concern and empathy for others. Lone in 2014 defined compassion as the recognition and empathetic understanding and emotional resonance with the concerns, pain, distress, or suffering of others, coupled with motivation and relational action to ameliorate these concerns. And then ultimately, Rohr in 2021 defined it as the empathetic and collaborative processes that promote involvement are non-directive, personal, and more likely to lead to continued services, empowered families, and positive experiences. So this, to me, if we take all of the best parts of these definitions, it's going to be very difficult for us to come up with a truly operationally defined an operational definition, of compassionate care. But what I think we can pull from each of these is that compassionate care is the immersion into another person to understand and reduce their distress from an empathetic or concerned perspective with the intent to promote collaborative, non-directive, and empowering support. Now, if you think of it and you have something in mind that you think should be added or removed from this, make a note of it. I want to hear your thoughts at the end of this presentation. But I also have a rhetorical question for you. Do you think that we can ever truly, fully create a behaviorally operational definition of compassionate care? Or is there always going to be some element of mentalism in there? Again, write those down, put a pin in it. I'd love to hear your thoughts at the end. Now, we operationally-ish defined compassionate care, but let's bring it back. So if we have a rough definition, and that definition based on the understanding and reduction of distress from an empathetic and concerned perspective with the intent to promote collaborative, non-directive, and empowering support, adding it to the measurement in which we develop a scale that measures the provider's ability to ease pain, anxiety, and emotions, both sensitively and attentively, in a way that helps the patient understand the issue and their options, and encourages the patient to ask questions and be involved in their treatment. That's how we ultimately start to incorporate compassionate care into a behavioral definition and measurement. These two things together are ultimately going to be what helps us perpetuate compassionate care skills training into the future. But that brings us to the most paramount question of this presentation. Can it be taught? So the barrier here isn't teaching ultimately, but rather teaching compassion. But as Joe likes to remind me, if it's a behavior, we can teach it. So I think when I first started this presentation, one of the things that I really got hung up on was, how do we teach compassion? Compassion is an emotional disposition. It tends to be shaped through our learning history. If you don't develop it as a child through whatever unfortunate circumstances, can you ever develop it later? But if you haven't worked with Joe yet, I highly encourage you to do so, because she always brings it home. If it's a behavior, we can teach it. Assuming that people have had an opportunity to develop compassion, and I'm optimistic that most of us have, then we have the ability to teach compassionate care. Now, teaching compassionate care, first of all, we have to, define it as per the Dead Man's Test. We can use that as evidence for compassionate care as a behavior. And this may be anecdotal, but ultimately I've never heard of a dead man providing compassionate care. So check, passed our test, done and dusted. Ultimately, though, Sinclair et al. Suggests that if we are going to start implementing these compassionate care educational models, that these interventions be grounded in empirically based definitions of compassion, that they use a competency-based approach, that they use multimodal teaching methods that address prerequisite attitudes, skills, behaviors, and knowledge, that they evaluate the learning over time, and finally, that they incorporate patient, preceptor, and peer evaluations. There are some barriers, though, to teaching compassionate care. Summarize them for you there, but ultimately, a lot of the interventions are limited since they focus on a single domain of compassion. They don't adequately define compassion. They're assessed exclusively by self-report. They're almost always devoid of a control group. They don't evaluate retention, sustainability, or translation. And they have difficulty generalizing to clinical practice over time. So things to consider if we are going to make this a stronghold in ABA curriculum. Now, expectations in delivery of compassionate care. So I'm going to pause here and just kind of invite you guys in a moment onto my journey. As I said in my intro, I'm a PhD student at Endicott College studying ABA. I'm a clinical counselor by trade. When Joe and I speak about the curriculums for ABA versus counseling, one of the things that always strikes me is that to be a counselor, I had 3 years of essentially compassionate care skills training. And right, counseling is generally considered more mentalistic than ABA, and I understand that. But some of the things generalize to both professions. It's being able to listen to our clients, to our stakeholders, making effective eye contact, remaining relaxed and neutral, learning appropriate body language, those minimal encouragers, and paraphrasing that feedback. So in essence, compassionate care is something that sparks my passion. My research targets first responders, so police officers, emergency medical technicians, firefighters, advocates, and my current research question involves measuring the level of compassionate care inherent in these professions. We expect them to have compassion, but we don't really teach these first responders in-depth training. So pending IRB approval, I'll have a developed survey to better understand their individual understanding of compassionate care, but I will keep you all updated, IRB pending. Now, behavioral skills training for compassionate care is essentially behavioral skills training for any other skill that we want to teach. It's instruction, it's modeling, it's rehearsal, and it's feedback. Extending this beyond, though, those first responders or whomever you're teaching these skills to are ultimately our clientele. It doesn't matter if your clientele is a child with a learning disability, or in my case, someone who has survived a catastrophic trauma. Ultimately, they value these soft skills full stop. Even if soft skills are not a primary reinforcer, they are still a reinforcer. Now, the skills that we talked about ultimately emphasize the importance of easing pain, anxiety, emotions with a sensitive and attentive approach to what the client needs. Also encouraging the client and their support system to have an active role in treatment. And that's where we get that star in the middle of all three of our Venn diagram. This is demonstrated over multiple participants, settings, and professionals. These skills need to be prioritized, especially in future ABA curriculums. So, looking towards the future, understanding compassionate care is paramount. It's critical. It's not just critical for us, but it's for everyone who comes after us. Defining compassionate care from the perspective of ABA can be tricky, but honestly, maybe that's okay for now. More concrete terms will develop over time, and we've seen that in the progression from 2007, 2010, 2014, and 2021. Together, we kind of defined compassionate care as the immersion into another person to understand and reduce their distress from an empathetic or concerned perspective with the intent to promote collaborative, non-directive, and empowering support. We measure compassionate care as important as defining it, and examine three scales, that being the compassionate care assessment tool, the compassion scale, and the Schwartz compassionate care scale, and analyze that overlap between those three. So just from a reminder that all three of those scales emphasize the importance of easing pain, anxiety, and emotions, both sensitively and attentively, explaining the issues in a way that helps the patient understand, and ultimately encouraging the patient to ask questions and be involved in their treatment. So we can conclude that if someone has compassion, they can be taught compassionate care. Behavioral skills training for compassionate care follows the same model as any other behavioral skills training. So with instruction, modeling, rehearsal, and feedback. And ultimately, ladies and gentlemen, if it's a behavior, we can teach it. And that's all I have for you. I'd like to open the floor for any questions or comments.
Thanks so much, Jeredith. That was really interesting. Really interesting stuff, and quite unique sort of body of work. That's so important. I think I'm with you that is something that we need to focus much more upon in our field. But going to the chat, I mean, there aren't any questions in the question and answer boxes, but I think most people tend to use the chat anyway. Penny's put, looking at people around me, and the most compassionate people are people that have experienced hardship. Do you think this is necessary to engage in compassionate behavior?
You know, honestly, if we're going to define compassion as a product of hardship, then I think we would be hard pressed to find anybody that hasn't experienced some hardship in their life. With hardship being different from me to you to those around us, if that's what we're defining it as a product of, then possibly. But I think we would have difficulty defining hardship as the predecessor to compassion.
It's appearing now. It's hard to teach compassion when staff are burned out. I think that is, I think, something that we come up against, isn't it, in our field, certainly.
Now, there is some interesting research, and it's still developing, if I'm totally honest, that suggests if we can teach compassionate care, then the rate of burnout is lower. People are able to greater. So we may have greater staff retainability if we can prioritize compassionate care in the beginning.
Yeah, and we had some presentations around sort of leadership and management structures and those kinds of things, and supporting engagement in teams, and those sort of compassionate approaches within those kinds of relationships are equally important as well, aren't they? Compassionate relationship with the team that you're managing and overseeing. I think those principles are the same, aren't they? And are going to hopefully benefit the team. Some people just want a bit of a recap on some of the acronyms and those kinds of things. I suppose the presentation will be made available, won't it, for people to look back upon.
Absolutely. Please don't mind my notes in the bottom of the presentation. I think I've made Joe laugh a couple of times with just perhaps some uncouth vernacular like WTF, why are we doing this? But yes, all of those acronyms are going to be explained. CCAT is the compassionate care assessment tool. The CS is the compassion scale, and the SCCS is the Schwartz compassionate care scale.
Wonderful. Were there CEU words incorporated, those captured?
Yeah, so we just need to give the 2 CEU words.
I would love to give those CEU words. Joe, can you text me? I don't know where I got the CEU words. I'm so sorry.
Just make them up right now, and I will write them down. So whichever words you would like.
Oh my gosh, that's so much pressure. Okay, so your CEU words are right and left, just like your hands. Right and left.
Would you advise introducing compassionate care at a managerial level prior to working with staff directly?
So that's an interesting one. I think ideally when we send people to any training for working with direct patient care, that's when we should implement some level of compassionate care training. But if management are going to be the ones that are supporting staff more directly, then perhaps they deserve a higher onus of training themselves. But I think that everybody can benefit from this level of training.
Yeah. Just it feels like it's something that would benefit more than just of ABA professions. It's kind of model that could be incorporated in any kind of leadership training or anything where you're working with people, really. I guess. Exactly. Going through lots of stuff is just sort of comments on some of the points that you've made and people agreeing with you and those kinds of things, which is great. So yes, it's a collaboration with some of those thoughts. Any other sort of pressing questions from anybody else who'd like to capture Jeredith while she's here, or something's appeared in the other box? Do you think teaching compassionate care can also potentially relate to training RFT's dietic relational frames?
Yes.
A relational frame theory question.
Absolutely. I think that that's foundational in just how we start to develop not only a perspective of ourselves, but how we start to develop perspectives of others and how we start to relate personal feelings in that projection onto others. So I sometimes hesitate to bring RFT into these discussions because I think it's one of those theories that like people hear and they're like, it's a bit much, guys. Can't deal. But that being said, I think there's so much to be gleaned from incorporating these two things together.
Awesome. Yeah, I like the sound of that. More a question around some of the practicalities of the teaching here. So we'd love to hear your thoughts as to how this should be taught. So for example, make up a scenario, present it, have that person react to it, that kind of thing, the behavioral skills training approach. Is that sort of how it's done, quite literally?
Yes. And it's able to be individualized as per your setting. So for me, working with survivors of sexual assault, that's mainly the demographic that I work with. When I train first responders, I train them based in situations where someone has just reported a sexual assault. But that being said, we can follow that exact same model and incorporate it to whatever workspace that you have. So if you're working with children with autism, and maybe you want to be a little bit more compassionate towards their parents or towards the staff, then we can create a scenario based on that situation easily.
Yeah, and I suppose video modeling would be quite a useful tool as well, wouldn't it? Like your videos that you've produced and that kind of thing, and watching yourself back and those kinds of approaches. Awesome.
I will say, whenever I have to have a difficult conversation, this is an old trick that we use. I practice in the mirror so I can watch my face. I have what the youth call the RBF, so I have to make sure that I actively prevent against that.
Okay, yeah, fair enough. Is there a way to assess if a person has compassion before starting to teach?
That's a good question. There are, most of the scales that I have come in contact with focus on the relationship between a provider and the patient. I don't know if I have yet found a scale that is a self-analysis of compassion. That being said, it may exist and it may have just not prioritized finding that. But if not, then that sounds like a wonderful research tool for us to develop. We know that self-report is kind of questionable, super questionable, but I think it may have some support in providing evidence to just somebody's own personal value.
Yeah, get that baseline and yeah, see the effect. Yeah, again, it sounds really interesting, quite unique. Sorry, I'm not giving anyone's names to these questions. Sarah says, do you think to be compassionate of a person's experiences, we have to step away from our own personal opinions and accept their experience as they tell it? So
this is interesting. So the earlier definitions that we had of compassionate care really focused on sympathy versus empathy. I think that stepping away from our own personal opinions is always a great place to start from. But I think being rooted in similar experiences of pain is ultimately a great foundation for establishing that empathy. So I may not have had that same painful experiences that you have, but I've experienced pain, as have you. And with that common ground, even though I may not have walked in your shoes, I'm able to understand at least that some semblance of pain. And with that, take into consideration how I can help you better based on that place you're coming from.
Yeah, awesome. Really interesting. And Penny's just reminded people there's a BACB presentation today around trauma and sort of linking it in with potentially some of the bits that you're talking about as well, which sounds really interesting. But I think that's all of the questions. I think everything else is sort of just comments and chat and that kind of thing, which is always nice to see. So it's speak now, forever hold your peace. If there's anything else that you want to field, but if nothing else pops up, then thank you so much. It's been really interesting. I've definitely taken away lots from this talk, Jeredith, and it's been great to meet you and listen to your work. So yeah, we'd love to see how that develops and evolves. But thank you so much for giving up the time.
Yeah, I appreciate it. Thank you so much for having me. I've greatly appreciated being able to talk to you all today.